job. Thank you.
Did a great job with the name. Yeah, hello everyone. I hope you enjoyed your food. And I have to start with a disappointment. I'm not going to talk about subclinical AKI, but I'm trying to convince you with another topic. So I am supposed to talk about the role of proenkephalin in assessing recovery from AKI, or the difference between transient persistent AKI or AKI-D, what we already learned. But what I want to do is I would like to start, of course, with my disclosures. They have no impact on my conclusions today, with the concept of AKI grading and some informative slides. We already heard something about that. I tried to illustrate it a bit with figures. I recently discovered AI for me to create pictures. I had to use it, sorry. So let's start with the functional concept, and you all know this. We use creatinine, a marker that is released from our muscles. It's transferred to the kidney, then cleared by the kidney. We find it in the urine, and we get an equilibrium, and this means that we have a stable creatinine level in our blood. When we have kidney injury, on the other hand, less creatinine is excreted. We detect this as an increase in creatinine. And this is then what leads us that GFR is actually dropping, and we make an AKI stage out of it. But certain factors affect creatinine independent from renal function. This is muscle mass. We already learned that. And also the volume of distribution in our septic patients when we load them with liters of volume. This also dilutes creatinine independent from kidney function. What about damage? Damage more or less means that cells are damaged or are under stress, and they release some proteins, and we can detect these proteins in blood or urine. And we think, at least we think, that the higher these levels are, the higher the damage in the kidney is. But how does that affect our definition of recovery, and what is the implication for that? And for that, we first have to define what is recovery. We've seen this figure already. I want to point out a few things. So we already learned CKD is after 3 months, AKI-D after 7 days, but what is really not that clear is the first 7 days. So what is transient AKI? What is persistent AKI? Usually you see 48 hours as a dividing mark, meaning when the kidney function is recovering within 48 hours, then it's transient AKI. When it's longer, then it's persistent AKI. I'm not sure about 48 hours. I would tend to 72 hours perhaps, but this makes it very difficult to define this. And when we look at individual patients, for example, you see that there are individual disease courses. You can have AKI stage 3 in green here that somehow recovers to AKI stage 2, then it goes over in AKI-D. You can have AKI stage 2 that recovers into AKI stage 1. You can have AKI stage 3 that recovers immediately to no AKI. And even you can have, it is illustrated in yellow, you can have no AKI at all. But over the disease course, you see that the patient actually develops chronic kidney disease. So it is not that easy, and it's also not that easy to define transient and persistent AKI. At least in my opinion. But why is this important? And this data from, it was 2016 already, shows this pretty nice. It is actually important for our outcome. So we have to define it. The question is, how do we want to define it? But when we have here in green, I try to use it, it's very hard to do that. You're right. I can't do it. Okay, so in green, early sustained reversal, of course, has the best outcome. Never reversed AKI has the worst outcome. When we have a late sustained reversal, then the outcome is better. So you see, definition of these different disease causes matters. But how does it affect our biomarkers, or these concept of biomarkers affect the definition of AKI recovery? And when we look at functional biomarkers, it's important to remember that kinetics of creatinine are not that good. What you see here in red, GFR drops to 0 and already on day 1 improves. So AKI is somehow recovering. But you see that when you use creatinine much later in a decrease in creatinine around day 3 or 4. And then this is why the question is when we use functional biomarkers to define AKI recovery, is it then all about kinetics? Do we need biomarkers with better kinetics? And what is a relevant improvement? So a drop of 30%, 50% back to baseline. There is a lot of controversy, and we haven't defined that clearly yet. On the other hand, the next question is creatinine the right biomarker to define AKI recovery? Because it's a slow biomarker. And what do we do with creatinine under renal replacement therapy, since it is cleared by the procedure? So we use diagnostic information, because all our patients, or the creatinine in all our patients is removed. What about stress damage biomarkers? There are also, at least for me, a lot of questions. We think that the higher the biomarker, the more likely the patient develops persistent AKI or even AKI-D or CKD. But is that a linear correlation? Is there a saturation? What about when we have a biomarker resolution? Does that mean kidney function is recovering, or does it just mean the driving pathophysiology has stopped? And this brings us to another question: what about the remaining kidney function or the remaining functional capacity of the kidneys? We're actually not able to detect that with damage biomarkers. Therefore, we would need function biomarkers, but they have poor kinetics. So with all these limitations, there are a lot of interesting studies, and we already heard about CCL14. Many studies, I picked this one because it's one of the largest. The authors looked at non-recovery, so the opposite of recovery, what I'm supposed to talk about, but it's easier to talk about non-recovery, at least on the data we have. The authors defined persistent AKI based on the time frame of 72 hours and looked how or what biomarkers can actually predict that. They included different biomarkers, cystatin C, proenkephalin, we will hear more about proenkephalin later, also damage biomarkers in the urine, and CCL14. So, and what they showed is that actually CCL14 in the urine predicts persistent AKI, stage 2 or 3, and that the level of CCL14 in the urine actually was also associated with poor outcome. So this is what we want to do. We want to identify our patients at risk for persistent AKI and, of course, poor outcome, hard outcomes. But what about liberation from renal replacement therapy? And this is actually a special form of AKI recovery, perhaps the worst form you can think of. And in this study also already, you see actually that when we have a failing liberation trial, the outcome for the individual patient is poorer than when the liberation trial was successful. You see that for ICU, a life of renal replacement therapy, death in general, and also for hospital death or a life of renal replacement therapy. The question, however, is this because our timing is bad, because we liberate too early, or is this because these patients were just sicker than the others? We don't know that, but it affects outcome. So what can guide us then when we want to liberate a patient from renal replacement therapy? And this is a nicely meta-analysis and review. The authors looked at different biomarkers, functional damage biomarkers, and also, of course, urine output. I personally think urine output is at the moment probably one of the best biomarkers, or at least we need biomarkers that have to be better than urine output, that we can use them in clinical routine. So when you look at serum creatinine, and then what is really important is when have they measured creatinine to predict successful liberation. And this shows pretty good area under the curves, and I was wondering how that is actually possible, because creatinine is cleared, at least on the continuous form of renal replacement therapy. And when you see when it's measured during CRRT, here in this figure, that the area under the curve is not that great. Okay. However, when we look at other possibilities to measure creatinine, for example, 2 hours creatinine clearance, the area under the curve to predict a successful liberation was actually pretty good. But when you look at the data, they haven't specified when they have measured it. So my question is, was it intermittent form of dialysis? Then it's probably easier, and you would assume that it helps to measure it. But when it's a continuous form, I would say, how do you get that information and end up with such a great area under the curve? What about other biomarkers, serum cystatin C? And this serum cystatin C has the same issue. It's cleared by renal replacement therapies, depending on the modality used, but it is cleared. So same problems with, as with creatinine. And also other biomarkers, NGAL here, in some studies it performs pretty well, in others it doesn't. When we look at urine output, so far I would say the best indicator that we have, that we use in clinical routine, all the studies showed pretty good area under the curves, around 0.87. However, they looked at this urine output after discontinuation. So this is actually not what we want. We want to decide it earlier and not do it and then decide afterwards. So this doesn't make sense. So this brings us now to what I want to talk about today, proenkephalin. Proenkephalin is supposed to be a new kidney function biomarker. It is derived from a same precursor molecule as endogenous enkephalins. And it is supposed to be produced in the central nervous system. It is a small protein. It is not protein bound, and it should be freely filtered. And it is associated with poor outcome, also renal outcomes. And it was also nicely shown, among others by Peter Pickers, that it correlates nicely with gold standard measure GFR. So it seems to be a great kidney function biomarker. So what about penKid, proenkephalin to predict AKI non-recovery, the opposite of recovery? And here, colleagues Mathieu Legrand looked at proenkephalin in a sepsis cohort at the time of ICU admission, and what they found was actually that when the patient had higher levels at the time of ICU admission, it was linked to worsening of renal function, what was the opposite of transient AKI. Also, the patients more likely needed renal replacement therapy, and also MAKE was higher in patients with higher penKid levels at baseline. This signal was also present at day 1 and day 2 or 2 days later after ICU admission. We also have data on this. We haven't published it yet. It comes from a study, a sepsis cohort study, where we included patients, 200 patients with sepsis diagnosis at the time of ICU admission. Primary endpoint in the study was RT or death, but that doesn't matter for this analysis. What you see here are, on the left-hand side, penKid levels over 7 days or 6 days, and on the right-hand side, creatinine. At time 0, sepsis therapy was started. And then you see in white patients who later required renal replacement therapy. In lighter gray, you see patients with moderate and severe AKI not requiring RT, and patients with no or mild AKI in a darker gray. And after the start of sepsis therapy, you actually see an immediate decrease in patients with moderate and severe AKI not requiring RT, implying that the kidney function is improving. However, when you look at creatinine in the same time frame, you don't get that signal. The same signal, however, is present in creatinine, but 3 to 5 days later. The increase is later. That means it seems like penKid is a faster biomarker in response to the start of sepsis therapy. What about cystatin C? This was very surprising for me. No signal at all in our sepsis patients. So they stayed in the same level, these patients. I don't know why was the inflammation that caused that, but they stayed pretty in the same level depending on their AKI stage. Good. Next, we have to talk about liberation from renal replacement therapy and the potential use of proenkephalin in this setting. And here, Alex Starbuck and colleagues did a post-hoc analysis of the ELAINE trial that actually was designed to combine early versus late initiation of renal replacement therapy. And they looked at low penKid levels or high penKid levels at the time of RT start and 3 days later. Low was defined as lower than 89 picomole per liter or higher, and actually found that patients with lower levels had a higher, in these patients, the RT liberation was more likely successful than in patients with lower levels. And this was also true 3 days later, so on day 3 after initiation of renal replacement therapy, also penKid was able to do that. Somehow, to give us, it seems like penKid seems to be not affected by renal replacement therapy, and we get that information despite renal replacement therapy. In a second analysis, same group, Alex Sarbok, did the same thing, but in another cohort. This was the RIDGE trial. Now they used a different cutoff. It was 100 picomole per liter, and they found no signal. At least at baseline, penKid was not able to predict a successful liberation from renal replacement therapy, but they found the same signal 3 days later. This time, they also included urine output and found that urine output was actually best in predicting a successful liberation trial. Urine output before the start and before day 3. This was the case at start of renal replacement therapy and also 3 days later. However, the problem that I see with their study is that we had fixed time points. And we have different patients. One patient needs dialysis for 3 days or renal replacement therapy, the other one for 4 days. So you miss a lot of information when you just say we measure penKid in all patients at day 3. Doesn't make sense in clinical routine at least. And this brings us to our study. This was a prospective evaluation in clinical routine of proenkephalin. It's called the PARTICIPATE trial, and I'm going to show you our data on ICU. We also have data from patients on a normal ward and also in kidney transplantation. We implemented it in our central laboratory and measured penKid from Monday to Friday. So far, at least for the ICU cohort, we included 1,477 patients. And what was important, 247 of them required renal replacement therapy. And of these 247 patients, 63 were already on dialysis prior ICU admission, meaning they were on chronic hemodialysis. The liberation trial that we looked at was defined, the start was defined as 48 hours without renal replacement therapy, and the liberation trial was considered successful when a patient did not need renal replacement therapy for 5 or longer days. So now you see here, and this is really interesting, creatinine levels from the start of renal replacement therapy, depending on whether we use the continuous form of renal replacement therapy or intermittent form. On the other hand, you see proenkephalin levels. And what you see for creatinine is that in the beginning, of course, it is different, and you see that continuous form are more efficient to reduce creatinine in comparison to intermittent form, because we have that rebound in dialysis-free time frame. But what you see for penKid is that actually penKid is increasing in all patients, like it's not affected by the renal replacement modalities. So is it then that penKid can give us an idea about the functional capacity under renal replacement therapy? And to confirm that, or at least to get the same idea, we looked at patients with acute need for renal replacement therapy and these 63 patients with chronic hemodialysis. And you see, when you look at creatinine, in the beginning, patients with chronic dialysis prior ICU admission had significantly higher creatinine levels compared to patients with acute need for renal replacement therapy around the start of renal replacement therapy. And then, of course, in both cohorts, creatinine was removed, and there was no difference around day 2. However, when we look at proenkephalin, and this is, I think, a very good signal, we were able to distinguish between these two groups at any time from the start of renal replacement therapy, meaning that it somehow gives us really an idea what the kidney function is, or the remaining functional capacity, for the first time, and in contrast to other functional biomarkers we have. And now, what we haven't had in the analysis from Alex Sarbok, penKid levels around the time of last renal replacement therapy. In purple, it's shown in purple, and we have creatinine, penKid, and urine output. And what you see in comparison to creatinine and urine output, penKid has really the highest area under curve, at least in our cohort, for predicting a successful liberation. Of course, urine output is still important, but it shows us really that penKid has additional information and also could benefit from a combination of urine output and proenkephalin, meaning that we really get, again, a functional idea of the remaining capacity of the kidney. This is my last slide in kidney transplant patients, and delayed graft function, you probably have heard of it or you have clinical experience with it. It's actually the AKI non-recovery of kidney transplants. And we looked in these patients our idea was to predict delayed graft function and compared the diagnostic performance of creatinine and proenkephalin and found that changes of penKid from prior transplant to the day after compared to creatinine changes were superior in predicting delayed graft function with a very high area under the curve of 8.7. And even after a multivariate analysis, including other factors that are important for delayed graft function, we really see that penKid is the dominating force to predict delayed graft function. I think that's very great. And it was also able to, I don't have that slide with me, to predict the severity of delayed graft function in the further time course after transplantation. So with this, you made it. I come to my conclusions. I've shown you that the trajectory of AKI recovery is important for outcomes, so we have to study it, we have to understand it better. We need a good definition for it. I've shown you that kinetics of established kidney function biomarkers are not optimal, especially under renal replacement therapy because they are removed by renal replacement therapy. Damaged biomarkers, on the other hand, they have a role, but the question is how are the kinetics, what is the time of measurement really plays a role. I've shown you that proenkephalin may help or assist in combination with other biomarkers or urine output since it has a faster kinetics than creatinine, so it shows us really, at least in our sepsis cohort, that kidney is improving. This was, by the way, also associated with an improvement of SOFA score at the same time. I've shown you that proenkephalin somehow seems to be not affected by RT modalities. Perhaps it's an equilibrium from removal and new production, but it gives us an idea about remaining kidney capacity. At least this is our hypothesis. And it also may help us to identify patients at high risk for liberation failure, or on the other hand, patients with an unnecessary prolongation of renal replacement therapy, and that could help us in the future to unify our treatment standards, because I think there's a lot of diversity and when to stop renal replacement therapy, and I think we all can improve that. Thank you very much for your attention.